Yeah, I think you can read out, Dr. Lakshmi.
Yeah, so the first question is why antenatal steroids other than betamethasone and dexamethasone are not used for prenatal steroid benefit. They do not confer any prenatal steroid benefit. Why do we use only betamethasone and dexamethasone? Hydrocort is also being used, but predominantly only these two steroids are being used. Reason?
Yeah, others can write in the chat box. All the fellows can start writing in the chat box. Don't write big answers, just one liner.
Are we getting any answers, Sriram?
Safety, I got one answer.
Only one answer?
Yeah, but wait,
Cost benefit,
benefit.
bioavailability is better. How much time do they have to answer this, each question?
It's nothing like that. After we get few answers, I think you can discuss.
Neurodevelopmental outcome metabolized from maternal circulation. Hydrocort adverse outcome. Placental transfer is less. Close enough, but not the exact answer which I want. Crossing placental barrier, again close enough. So shall I say the answer?
Yeah, please.
So this is because of a particular placental enzyme, that is 11-beta hydroxysteroid dehydrogenase. Only these two steroids are not metabolized by this enzyme, so they can cross the placental barrier. All the other steroids do get metabolized by this and so do not cross the placental barrier. So that's the answer for this. So we'll go to the next question. Yeah. Factors influencing placental blood flow during delayed cord clamping. And which is the most important?
Yeah, you can mention the most important factor. Please mention the most important factor determining the blood flow during delayed cord clamping.
Just state your answer in just a few words. You don't have to write sentences. Pressure difference, you mean the gravity? Position of the baby, duration. Anything else? Spontaneous respiration, very good. Holding baby below placenta, that is gravity. Any other answers? Okay, so all the answers mentioned here are correct. That is the cord clamping time. 1 minute is less than 2 minutes, less than 3 minutes. Again, 3 to 5 minutes, there is not much of a difference, and beyond 5 minutes, once the cord pulsation stop, again there is no difference. So hemodynamic stability of the mother, the cord clamping time, the cord pulsations, gravity, and the most important, I feel, would be the fetal breathing movements, the negative intrathoracic pressure being created by the baby. So the delayed cord clamping time and the fetal breathing movements are the most important factors which influence delayed cord clamping. So the next question is, which single ventilation parameter minimizes CO2 fluctuations and thus minimizes the risk of PVL or brain injury in preemies. So we have several modalities of ventilation. We know different terminologies in ventilator settings. So which is the most important setting, which if we can control, can minimize CO2 fluctuations. Anybody else? Tidal volume change, volume guarantee. I'm glad that all of you are giving me the right answers. So it's the tidal volume, which if we can regulate, it's not the map, it's the tidal volume if we can regulate. CO2 fluctuations, hypocarbia is especially very dangerous to the brain, causes severe cerebral vasoconstriction and increases the risk of PVL. So if you can control your tidal volume, and this can itself minimize your CO2 fluctuations. We'll go to the next question. What are the biomarkers for NEC, necrotizing enterocolitis? Platelet activating factor. Anybody else? IL-6? Is it IL-6? No, I want more answers. IL-12, DR4, IL-6, PF, calprotectin, wonderful. Okay, so the answer for this is there are two biomarkers, serum fatty acid binding protein and fecal calprotectin. So fecal calprotectin is also very sensitive and specific, but the problem is we have to wait for the baby to pass feces and then we need to test it at that point of time. So it is the passage of feces by the baby, we are dependent on that. Serum FAPP is a better marker for NEC. So all necrosing cells will release this protein, which is taken into the bloodstream, and then we can assay the sample. So serum FAPP and fecal calprotectin are the right answers. And the last question for today's session would be why barbiturates and benzodiazepines are not effective anticonvulsants in neonatal seizures. Even though phenobarb is the first line anticonvulsant in most of our units, but most of the time they do not or they cannot control neonatal seizures. Likewise with benzodiazepines. What is the reason? Good. Immature blood-brain barrier. GABA is excitatory. Any more answers? So yes, the answer for this is because seizure mimickers. The answer for this is both barbiturates and benzodiazepines are GABA agonists. And unlike in pediatrics and adults, in neonates, especially preemies, GABA receptors are excitatory and not inhibitory. This is because they cause calcium influx and they hyperpolarize. And so they are inhibitory rather than, they are excitatory rather than inhibitory. And over a period of time, generally around 37 to 44 weeks of gestation, then they have their inhibitory actions. So sometimes they might not work because rather than control seizures, they might still perpetuate seizures. Dr. Sriram, I think we are done with the session.
Yeah, I think that's it. Thank you, Dr. Lakshmi, for sparing your valuable time and giving the MCQs. And I thank Dr. Nalinikanth also for sharing his thoughts on two important cases.